Good afternoon, everybody. Thank you so much for joining our third crucial conversation. My name is Lindsay Jennings. I'm the Director of Development for the Institute for Humane Studies. Please note that we are recording this webinar, so those who are unable to attend the live event can enjoy the program later. I would first like to thank all of our supporters and donors who have joined us today. Because of you, the achievement of a freer society is possible. Your investments are critical to discovering and investing in talented students, scholars, and other intellectual entrepreneurs who are advancing the principles and practices of freedom. The Institute for Humane Studies is building a network of high-impact scholars and research communities to span generational, disciplinary, ideological, and professional divides to develop and advance the ideas that support thriving, free societies and widespread human flourishing. At IHS, we believe that diverse viewpoints and the exchange of ideas are essential to a free and open society. We believe that fresh ideas and civil discourse are needed now more than ever. They matter inside universities, in public policy, and to each person on this call. That is why we started Crucial Conversations. The series aims to bring you some of the best and brightest minds in their fields, applying their knowledge and research to solve today's most pressing problems. Today, our speaker, Alicia Plemmons, will talk about how removing barriers to healthcare can be as simple as rolling back unnecessary regulations. She will be speaking about some of the policy wins she and her team have achieved and how that has helped save lives. I'm thrilled to introduce you to my colleague, Jean Hoffman, who will introduce you to our esteemed speaker, Alicia. Jean?
Hi, everyone. Thank you, Lindsay. Yes, as she said, my name is Jean Hoffman. I'm our Director of Coalitions. And before I get into introducing Alicia, I just want to let you know at the bottom of the screen of the Zoom window, there's a Q&A button. I'm going to be having a conversation with Alicia, but if a question comes up to you at all while we're having the conversation, feel free to ask the question in the Q&A section at the bottom. If you don't see the Q&A section there might be 3 dots to the right of the window, and you'll find the Q&A there. So don't feel like you have to wait until the end before asking your questions, because I know sometimes it's easier when you think of something as the conversation is happening to get the question out then. So we'll answer them at the end, but feel free to submit them at any time. But I'm incredibly happy to introduce Dr. Alicia Plemmons. I gave up a long time ago on trying to introduce her with all of her titles and all of the hats she wears, so I'm going to select 2 of the most important of them for this conversation. So she's an assistant professor in the Department of General Business at West Virginia University, but she's also the director of the Center for Free Enterprise and the coordinator of Scope of Practice Research and the research fellow in the NE Regulatory Research Center. So like I said, she has more hats than that. I don't know how productive she is. I don't know how she is as productive as she is, I should say. And I like to tell people I'm like a proud aunt of Alicia because she's been with IHS since she was a graduate student. And I had the opportunity and the privilege to see her blossom into all of the things that she is now, including an advocate for reducing barriers to entry into the labor market, meaning letting people have the right to have the jobs that they're trained to do, and reducing regulatory barriers that cost people opportunities, can also cost lives in some cases as we get to. So some of the research that Alicia has done is literally saving lives right now. Like I said, we'll get more into that, but she's going out there and she's testifying in front of state-based legislators. She's mentoring the next generation of scholars who are also pursuing this work in reducing these regulatory barriers that really have such an impact on our individual lives in different situations. So it's my pleasure to welcome Alicia Plemmons.
Thanks, Jean. This is going to be a lot of fun. Hello, everybody. Thank you for coming and joining today.
So Alicia, first, I know you get a lot of questions about the NE Regulatory Research Center, especially sometimes people think it's like orthopedics. So could you tell us a little bit more broadly about what the center does?
Absolutely. As someone who works in healthcare and I speak a lot related to healthcare related policies and bills, I do have to tell people the knee center is named after the family, not the body part. We don't do orthopedics. We can refer you to people who that's within their scope of practice because that's something that we like to study, and it's growing the amount of people who can help with these problems. The Knee Center was founded in 2016 at St. Francis University by my boss, Ed Timmons, wonderful individual, if anybody would like to meet him. And I know he's done some of these conversations in the past. with the goal of working on occupational licensing. So a lot of these barriers to being able to have employment. A lot of the time we don't quite realize that some of the reasons why 1/4 of our population is having issues getting to work or get their government permission is because that there's fees, there's education requirements. These licenses are set at the state level. They don't transfer in between states many times. And it's wildly different depending on where you live, what availability you have to even do if you're licensed there. So as the center kept growing, they moved over to West Virginia University, which is where we're currently housed, and I run our healthcare side. So I do a lot of the stuff related to looking at what you can do with the license once you have it, and I look a lot at healthcare specific issues as we try to provide more flourishing and prosperity for people in society by reducing this government overreach and a lot of this burdensome pieces that were put in for anti-competitive purposes.
So before we dive into the health pieces, let's talk just generally about licensing, because you were telling me some surprising careers that require a license before. Has it always been this way, or is licensing increasing over the years?
It's increasing. So I'll give you the short history. A lot of these licenses originally came around back in the Guild era. When the United States was first founded, there were only 3 real licenses. It was for physicians, apothecaries, and I believe accountants, like an accounting lawyer sort of mix. It's grown exponentially since then. In the 1950s, 4% of jobs required government permission to make a living doing the work that you have been trained to do. Now it is ballooned out to about 22 to 25% of the population, depending on how you count the civilian population. But that's a lot. That's 1 in every 4 to 1 in every 5 people who have to go through all of these different means to be able to make a living for their work. So licensing is a very crucial thing for us to study. It's one of those pieces where many times it's not the profession themselves wanting to increase licensing for the purpose of health and safety. It's them wanting to put in these different types of regulations to keep new entries out. So to be able to reduce competition, to be able to make it so that their competitors are unable to provide certain services. And a lot of these practices have started building up over time, and it's just gotten worse and worse. And we try to deal with those issues by looking at it from academic research and bringing that academic research to legislators.
So what would you say are some of the most surprising licensing requirements?
Oh, okay. So the one that we always pick on is Louisiana for being the only place in the US that licensed florists. This is now going to the Supreme Court for the second time. The first time the Supreme Court said that yes, they can keep florists licensed because what if there's soil contamination? The funny part of that to me is that they took a bunch of bouquets that were made by florists in Louisiana and all the surrounding states and presented them to people. And Louisiana always ranked the lowest in the beauty of their flower arrangements. Another one that I find surprising is hair braiding in a lot of places. So this is one that cosmetologists started asking for and starting requiring hair braiders to go through over 2,000 hours of training in some places that doesn't teach anything about hair braiding. The entire curriculum that they're going to have to spend 2 years of their life and close to $14,000 on average has nothing to do with hair braiding. So a lot of these different restrictions are very surprising. For example, North Dakota right now is licensing horse massagers because a group of people decided that veterinarians can't perform horse massage, even though they do in every state and they've been providing the service for 200 years. We have to have a whole separate license for it so that 4 individuals were able to make it so that they had no more competition providing services to racehorses. So it's just wild, some of these questions that we have.
Wow, that is crazy. And I mean, it's funny until you realize, getting into your research, that some of these licensings, they actually cost lives, or they cost wellness. They prevent people from getting preventative care. So let's talk more about your research priorities. So one that I've been really impressed with the work that you've done in is scope of practice, which is literally, right, limiting healthcare workers from performing jobs that they're trained to do. Like, they're trained and able to do these jobs. Is that correct?
Yeah, so people don't quite know that the limits on what you can do with your medical license really depends on what state you live in, and those restrictions are not made by healthcare professionals. Those restrictions are often made by state boards or state legislators or people who own hospitals who may not want new competition coming in. And these barriers can be substantial. For example, in some states, nurse practitioners can provide you medication. In other states, they can't. In other states, they can't even order a test or be able to look at an x-ray for you. So it's very varied depending on where you are. 2 of our biggest wins in this area lately have been related to psychologists. And that one's been a lot of fun to work with, and pharmacists. So psychologists, with that, we realized in a lot of places, there are deaths of despair, loss of life to suicide, especially as just really society has progressed into this more technological age. Social media has been a high presence. We've seen lots of loss of life to suicide. And for people to be able to get medical help that they need for their mental and behavioral needs was taking a really long time. So it would take 6 weeks to get your appointment with a psychologist, but that psychologist couldn't prescribe medication. So instead you had to get referred to a psychiatrist who would then go through a series of tests and then be able to provide you medication. So people who were going through crisis were missing medications that they needed for an additional 3 months on average. And that meant that there were lots of loss of life within these states. Louisiana and Mexico back in the early 2000s decided to do something about this and allow those psychologists at the very beginning of this process to start the medication for these individuals. And it was great. It ended up saving a lot of lives. Our research found this and we were able to take it to other states. We're now up to 7 states that allow for psychologists to be able to start these medications, which has saved hundreds of lives. We're doing similar with pharmacies. So Idaho was the first one to work with pharmacists because there's a pharmacist in every single county, but there were only 26 endocrinologists and I think 14 allergists in the entire state. So people who needed things like inhalers or they needed insulin treatments, they weren't able to get the help that they needed in a timely manner, which meant that these families were either going through disastrous medical outcomes or they were having to go to emergency rooms for care, which would cause medical bankruptcy and just disrupt these families' lives. So Idaho started by allowing pharmacists to be able to just prescribe basic things that pharmacists should be able to prescribe that they do in Europe and other places of the world. Being able to hand an inhaler to that person who they worked with their asthma for 14 years, to be able to hand an extra insulin dose to a diabetic who needs care before that they're able to go see their different provider, which might have long wait times. So this has been able to save lots of lives and keep people out of emergency rooms. Since then, we've helped Montana, Tennessee, and Colorado all put in similar policies. Because what we do is we do this sort of academic research that looks at how many lives are we saving, what is the financial impact on this, how are we helping with prosperity, and then we go and we explain it to legislators. And we really point down each piece of how we're making lives better and how we're increasing prosperity. And many times they decide to change these policies in response.
That's great. And I see in this situation how it's saving lives. I think with doctors versus nurses performing certain tasks, most people will assume, well, it's better for a doctor to do it, right? Because the doctor is more trained. So even if a nurse can do it, don't these regulations help you get the best type of care and increase safety?
What I've learned from working in healthcare research is I'm never going to ask a physician to start an IV for me. You should always ask the nurses. The nurses are much better trained to be able to place IVs. So nurse practitioners, wherever they go to school, they are going to be trained on psychopharmacology, pharmacology. They're going to be trained on being able to order tests, diagnostic supplies, and working with a collaborative group. But some states have gone one step further to be able to limit the things that they were trained on, that they have been able to do in many different states, and limit this to instead having only physicians providing certain services. This has caused a lot of issues. One, it makes it very difficult to get healthcare providers into especially rural communities or low income communities. So many of these rural states, unless there's a physician there to lead the team through an unnecessary contract, you're not going to have any nurse practitioners or other healthcare providers either, which means that you're having very long wait times. You are making it so that farmers are having to leave the farm for days on end to be able to go into town to be able to get certain medical treatments when they should have been able to get that locally. So that's one of the big things that we look at is if these people are trained and they have had a background into being able to provide these services, what happens from there? So a lot of what we look at is for access in primary care medicine, because that is one of the most important parts to prevention and wellness. And to preventative care is to be able to have that regular primary care access, which is actually the thing that's missing most in physicians. So right now we have I think it's a 20,000 physician shortage that's expected to be 135,000 as we have retirements coming in between now and 2030, if I'm not mistaken, because the number of residencies is capped in the United States. So it's not like we're able to increase the number of physicians coming in. And even if we do, over 85% of them will not go into primary care at all, but almost all nurse practitioners end up staying in primary care. So if we're wanting to increase this preventative medicine, one of the first places to look at is, can we get those nurse practitioners to be able to work to the extent of their license, to the extent of all the training that they've been given, and what can we do to make sure that we have access to healthcare in places that may not have had access to healthcare previously? one really interesting result that we did find from this, and it's something that we're starting to look at also with ophthalmologists and psychiatrists, but it's that when nurse practitioners are given more empowerment, when they are able to work in all these different things that they've been trained in, we call it full scope of practice or full practice authority. When they have that, not only do their malpractice rates go down, the physician malpractice rates drastically go down. We were wondering why that happened, so we looked into it a little further. It's because physicians started spending more time with patients instead of filling out paperwork for non-physicians that they were having oversight on. So it ends up being not only better for nurse practitioners and the community, it ends up actually being better for physicians too, when we allow the non-physicians who are trained to do these jobs to do these jobs.
That's great. And you keep talking about how you use your research to help make positive change in this area. And we've certainly seen it. There's been a lot of laws that have changed across the country. So even though you're based in West Virginia, you're having an impact anywhere this issue is coming up. But could you talk a little bit more, like, how does that literally happen? So how does you working on research turn into, this change?
Well, luckily, it's not just me. It's a great team. So we have lots of people who work on these questions, not only at West Virginia University, but we've developed a network of about 60 scholars in 40 different universities all across the US. So if there's a certain state who gives me a call in North Dakota about a healthcare issue, we've worked with the Charlie Institute. We can make sure that someone is there to be able to talk to them, that we can give them the updates on this research, we can get them involved, we can educate them so that they can also go talk to the legislators. That's how we've really been able to expand out to all 50 states. A lot of the time it's us on planes going and talking to these legislators, but many times these legislators want to talk to people within those states as well. So we're able to work with think tanks, other centers, with independent academics who may not have the support from their university. We have those resources. So we try to bring them in, really empower them in their own research, get them involved in projects, and then be able to teach them how to do things like op-eds or testimonies or working with their legislators. So we've really tried to make an impact in all 50 states, and we're very proud of that. We have so far this year, I think, testified on 34 different major bills. Many more outside of that, but 34 very major bills in the healthcare space where we were able to educate the legislative process, and has gone on to make it so that many new policies were put in place. And it's not only us, it's our entire team.
What do you think it is about the work that academics do that
Mhm.
makes your research persuasive to the legislators?
So the changes let's do nurse practitioners, the changes for nurse practitioners to be able to get more practice authority in alignment with their education and their training, those fights started in the 1970s. So why didn't the laws change in the 1970s? Because for this entire time, the legislative process has been angry physicians coming in and saying, we don't want new competition, and the nurse practitioners coming in saying, we want more rights to be able to do these things. But both of them, their paychecks at the end of the day are influenced by what happens with this legal structure. A lot of legislators really like that we take a nonpartisan approach and we go from academic research stating the facts. My paycheck stays the same whether nurse practitioners can increase their job or not. I'm there because we have hard-hitting data and we want to come in and we educate, not advocate, because we are a nonprofit and a university. And we look at all these different facets of, okay, well, what is this legislator upset about? What is their holdup? Are they worried about rural healthcare? Okay, well, here's all the data related to rural healthcare. Are they worried about what's going to be happening to licensing for military spouses who are registered nurses? That's one that we work on a lot, is issues with military spouses. We'll go in, we'll look at the research, we'll see how many extra people it gets back to work, how many military families it takes off of SNAP benefits or other social assistance programs. And we help those legislators figure out exactly how that impact their area. And once they have that education, once they understand a lot of this research that was not done by the parties fighting, this research done by like economists and people in sort of this classical liberal space that we have, how it influences these outcomes. And they are much more willing to engage with those conversations.
Now, I want to ask you about something because I've been at IHS about 16 years now, and I feel like it's hard for a regulation to surprise me at this point, even no matter how I feel about the regulation. I've seen a lot, but you told me about this, and I was honestly shocked, and I had no idea. So the area I live in, there's a lot of areas in the community that don't have a lot of access to like wellness centers. The MRI and imaging machines are very old. I will drive an hour to go to other facilities. And I just thought it was a thing that communities don't think it's worth investing in more equipment or more beds or more hospitals. And you told me about this thing called certificate of need laws, or as you often refer to it as con laws. Could you go into the details about that and what sort of
Oh my
limitations that
gosh.
creates?
Absolutely. This is one of my favorite rants. So for people who don't know, certificate of need laws are in, I think, 38 states right now. It started out as a policy in New York in 1964, which the federal government then ran with and said, we're not going to give you Medicaid and Medicare funding unless you implement this policy up in your state. So all the states except for Louisiana ended up implementing some version of this policy. Then in the 1970s, the federal government said, wow, that's a really bad idea. We're going to get rid of that. But still, many states still persisted because at that point, it had been making money for different hospital groups. They didn't want the policy changed. But what this policy was that basically for you to be able to make a new investment into your hospital, if you want to buy a new MRI machine, you want to open up a new labor and delivery service, you have to go get permission from the people already offering those services. One of the people we have working here, his name's Connor Norris, his mom actually worked on MRI imaging. And for her hospital to get an MRI, they had to put it on the back of a truck and to satisfy the needs of the community because the people who already owned MRI machines didn't want new competition coming in. They had to take this MRI machine 2 counties up 1 day a week and 2 counties over 1 day a week to be allowed to have an MRI machine. This also is the same for wellness centers. A lot of the times, if a new wellness center wants to open up in a location, they can be shut down if the local hospital does not want a wellness center operating there because they do have to ask permission. And that in most states, the existing infrastructure has veto rights. So people really wonder why we don't have new facilities or why we have such a limit in some of these healthcare services, especially because many of us have an economic background, supply and demand. If there's people who need this, we think that therefore they should be able to supply it. But what many people don't realize is that there's these 30-year-old policies that were put in place that started making money for many of the groups that were already established to be able to stop any new healthcare from coming in. And this has been detrimental for wellness, preventative medicine. It's been extremely detrimental for things such as cancer care. We've done a lot with dialysis centers getting shut down very regularly. It's been so heartbreaking to see some of this work. This is actually one where we're doing a really great job of working with the next generation of scholars as well. So not only do I work on Certificate of Need and many of my colleagues work on Certificate of Need, we're working on many of the PhD students, a lot of which we've met through the IHS network who have heard our talks about this and got interested. We start to involve them with research. So right now we have Christine, who just did some really interesting stuff about substance use disorder facilities, as well as Sarah Drain. When local hospitals can shut down substance use disorder treatment facilities, you end up just having much higher rates of substance use disorder along low income and homeless populations. You end up having more infants born with neonatal abstinence syndrome that actually costs millions and millions of additional dollars of Medicaid and Medicare funding. It's a little heartbreaking. So it's great that not only are we working on this problem, we have the next generation starting to work on this problem, and that because we're able to come at this from a very academic perspective, they're more open to listening to us in the legislative system.
And let me make sure I'm understanding this correctly again, because it's just, I don't even know what to say to it. So in most licensing situations, you have organizations advocating to put up barriers to people getting the license. So they have to overcome those barriers. But in this specific case, you're saying that the people who want to put up the barriers also get to decide whether or not the other person can overcome those barriers.
They get to choose the barriers. It's not government making the decision. Government just put in place the process that they have to go get permission from everybody. 2 heartbreaking cases that we worked on, because sometimes when there's a case that goes to a state Supreme Court, they'll also ask us for just what's the education around this, or to be able to write some amicus brief related to the work. 2 heartbreaking ones that we had were in Kentucky. There was a community that didn't have access to EMS services. It was an older community and it was taking 6 hours for people to get to an emergency department when they were having an event, which was causing loss of life, especially from things like heart attack. So this man spent his entire life savings getting a paramedic to move there, buying an ambulance, setting up all the needs that they needed to be able to run ambulance services in this town for the first time ever. And it turns out that a different ambulance group, 6 counties over, that were taking 6 hours to get there and deliver people to hospitals, were able to shut it down and say, no, we don't care that you spent your entire life savings and you're trying to save your neighbors. We technically offer services there, so you're not allowed to have that. And they had to shut down this entire beautiful operation that they had, bringing in paramedics and EMS services to this older community, and they still don't have care. So those are the types of really heartbreaking situations that we try to address when we're looking at this research.
That's terrible. But I'm really grateful and glad that you and the Knee Center and then your collaborators across the country are working on this issue because it's really important. And this is another area like the prescriptive authority where lives can literally be saved because if someone's having a stroke, they can't wait 6 hours for an ambulance. So that's terrible. Um, I just want to let everyone know there's about 5 minutes left in what I'm asking Alicia. So if you want to start getting questions in, I can start asking your questions when I'm done. So the Q&A button at the bottom, again, if you have any issues with it, I think you can message one of the hosts with questions. Oh, and I see people are already putting questions in, so that's great. But Alicia, I wanted to ask about your origin story. It's like you're a superhero. So I mentioned in the beginning that I've been working with you since you were a graduate student. It's been great to see what's happened. How is the Knee Center so big? How did this happen? Because you guys are having such a big impact in the world where you can literally see the change that's happening. But how did it get to that point?
Yeah, surprisingly, there's only 10 people here in person. Everybody thinks we're a much larger team than that. And the reason we're able to do that is because we have research affiliates in so many different schools. We get people really excited about this topic. A few times a year, we try to bring people in for a conference where we'll really encourage them to show us their research. We'll show them our research, and we have these open and honest discussions, and we'll really train them to be able to engage with a more public audience as well. Many academics have great research that impact their state, but they're a little hesitant to be able to say, hey, why is this happening here? Or my research will be able to help with this problem. And then taking those next steps, we try to inform them about those next steps. So all 10 of us do everything from operations to testimonies to op-eds to academic research to putting together databases so that if anybody needs to look up a licensing requirement for, I think we're up to 80 different occupations right now, we have it available on our website at any time for them. We have legislative trackers available for people. So some of the ways that we're able to be big is mostly because we're trying to empower others by building up resources here and then connecting people who may not be connected to centers or they may not have the resources in their state to be able to get those same things. Like if we get access to a really good healthcare data set, if we're able to purchase some of these larger data sets, for example, we work with James Bailey at Providence College. He's wonderful. He's an amazing individual, but Providence College doesn't have the money to be able to buy some of the data sets that he needs to do the high impact work on certificate of need that he does. So if we're able to purchase it here, then we can bring him in as a research affiliate to be able to work with that data over the summer, to be able to do some of this research. And then we help him figure out how to take that research and translate it outwards. So we're able to have a big impact because we really try to work with people outside of just our four walls.
And just to kind of show what a cascading impact connecting with those other scholars can have, can we go back even further in the origin story? Could you talk about how you started first working with Ed Timmons and how that turned into this basically?
So I'll do that, but I'll go one step further into how I met IHS because it's part of the story. So I was one of the people who didn't come from George Mason or WVU or Texas Tech or one of these places where the sort of classical liberal education was more a part of the curriculum. I came from the University of South Carolina, then went to Georgia State University for my PhD, where there's no one who thought like me. So I went to a conference. There was an IHS booth. They had these really interesting mugs, which I brag about all the time, but I'm at work, so I don't have my beautiful IHS mug is at home, or I would show you all. But they were these wonderful mugs. So I walked up and I just started talking like, oh, Schumpeter, I know him. He's great. I've read his work. No one else will talk to me about this. And we had such a good discussion. And I was like, oh, wow, I feel like I finally met people who think like me and really realize that fixing a societal problem is not putting another barrier up. Sometimes it's reducing the barriers that are there. So with that, I started signing up for almost every IHS event I could, and I started going to any of the like networking happy hours. I started going to some of the academic research symposiums where we had experts in topics. And one day, one of the ones that I sat in, because I was interested in bankruptcy law at the time, was this talk on licensing. I'd never really heard about it before. I sat in, and by the end of that, I was so enraged that I was like, this is fascinating. I'm going to study more into this. With that, eventually at different IHS events, I met Ed Timmons, who's the director of the center, and we started working together. Ed has worked not only with IHS, but has worked on being able to build really this coalition of young academics, old academics, graduate students, all bringing them together who have this sort of common interest so that we're all able to work together. And luckily, we've also been able to have lots of different programming where we're able to invite more people out to learn about these topics. And IHS has been such a great partner for this over time as we've run many of these events with y'all. We have 4 different conferences this summer, 3 of which I think you all are supporting some graduate students to be able to come up and learn more about this work that we're doing, and they can share their work and get interested and involved in projects. So a lot of my origin story is I was put in the right room with the right people, and we just started working together, and we got really excited. And with that, we started working with Shir Shakya because he was in one of the rooms in one of the events, and then we got Shripparna Ghosh, and then we got Moise Bay, and just it kept exploding out from there with more and more individuals who were interested, who luckily were put in the right room at the right time, so they were able to build this really big network.
It's great, and we really appreciate all the work you guys are doing because it's part of our goal to take. We call them the visionaries in the network who have this vision for a better future for everyone and what can be done, and helping provide you with the resources that you need in order to get that done. So it's things like this that really make me love my job because I get to see what you did. And like I said, I first met you when you were a graduate student, and you were like, I'm want to be a great professor someday. And I was like, I know you could be a great professor, and you're doing even better things than I could imagine because you're having such a big
Aw.
impact in the world. So thank you. All right, we're going to move to the Q&A now. So the first question we have is, what do you see as the next big hurdle to tackle in healthcare regulation?
Oh. So I keep telling everybody that my end goal is to put myself out of a job. I would love to think that eventually all 50 states are going to listen to us and they're going to fix all of their really bad policies. And then I'm going to have to find some new work to do. And that would be awesome. If I had to find what that new work is, let's say that I was able to fix everything with scope of practice. We got rid of these con law restrictions in every state. The passion projects that I had right now were finally being solved. The next thing I'd probably look into is right to try. So many times there are people who have life-threatening illnesses who are unable to try some of the new medical advances because they haven't gone completely through the FDA process, even if they're available in other countries. So thinking about for terminal patients, having the right to be able to try these potentially life-saving outcomes instead of waiting multiple years for regulatory hurdles that they're unable to wait for. That's something that I would really like to look more into, especially for the purpose of, again, human flourishing. And thinking about this wellness and what these medical advantages could have if they didn't have the same regulatory structure holding them behind for years.
The next question we have is, are there occupations where some form of licensing is useful? If so, what are steps to make these more accessible?
Sure. So I'm not ever going to ask for your home health aide to do neurosurgery in the middle of the street. And I don't think that's really what anybody's really aiming for when we're talking about breaking down regulatory barriers. A lot of the time, we're just trying to see, are these fees just keeping people from being able to join in this job? Is this something that they were trained to do that they're not allowed to do? And why is that? Some occupations where we've seen that there's actually some benefits to safety are around things like animal breeders and trainers. It turns out that there's much safer outcomes if there is these sort of like safety classes required for individuals before working with animals. And there's a few instances like that where we've seen some quality and safety outcomes. But in most cases, we have about 300 different studies we've done on quality outcomes across different occupations, and almost all of them, whether the license is there or whether it's a certification, whether it's a registration process, it doesn't affect much on quality and safety. So if we're talking about how to make this more accessible to people, some of the ways that we can do that is by one, increasing reciprocity. If someone is a fantastic physician in one state, they should be able to be a fantastic physician in another state. Turns out you don't lose your entire medical knowledge moving 20 feet over the border. By instead looking at other things such as like optional certifications. So one thing that I also do with my other titles is I work with the hospitality and tourism industry a lot, and everybody wonders how they're able to be so innovative. And why they're able to adapt to technology, why they're able to go to new practices, why they're able to do things a lot faster than other industries. And a lot of that's because they use more optional certifications. You can be a certified bartender. You can go and get your Sigma Black Belt in hospitality leadership. You can get other optional certification pieces. You can take educational credentials, but you get to pick what those are. There's not a list that you have to do of hurdles every single year that you have to pay fees for. You can instead work on the things that are most prominent for your job. And I think that's a way to make it more accessible, is to really start thinking about, do we need these 4-year degrees with $30,000 of fees, with all of these other pieces in it, but can we instead start thinking about training people for this job? Thinking about other things such as registrations or certifications, or the role of just public information. So the reason why most licenses came around, especially in healthcare, was because it was so difficult to have information in the 17 and 1800s about what this dentist did, if it was a reputable dentist, and what services that they provide. And it wasn't just for dentists, it was for basically all medical groups. So some of these licenses came in to be able to say, like, yes, this person is licensed and therefore they have met the standard. But today we have information. We have what was Angie's List. We have Yelp. Every single insurance actually has like ratings for each provider that you can work with on their portal that you can look up. So we have a level of information and detail about being able to keep people safe or where there's good services that just wasn't available at the time where licensing was created. And it'd be nice to see what we could do there to make it more accessible to get into these industries, and then allow the market to do what the market does by finding good providers versus bad providers.
What are some other regulations you and your network are researching that, if rolled back, could have a big impact, like some of the things you've already done?
Okay, yeah. So some of the stuff that we're working on, which is newer, it's run in our center by Darwin Deo, who's at San Jose State University. But again, that's one of the ways that we're able to work with people at different universities all over, is working on collateral consequences. So this kind of goes back to licensing, but it can be a little bit more than just licensing. Many times licensing will cost you a fee, it'll cost you education, it'll cost you some days of paperwork. One thing people don't realize is many of these licenses also say that they have a good moral character requirement, and it's very vague what this good moral character requirement is. It turns out that you might have an entirely unrelated misdemeanor or felony that stops you from getting that license, and often they don't tell you till you've paid for that 2 to 4 years of school. They don't tell you until after you've taken the exams. And that's can be very dangerous, especially for people who are trying to re-enter society. One kind of sad version of this that I always like to use as an example is firefighters in California. So when there's wildfires in California, one of the first lines of defense who work as firefighters are actually prison inmates who train as firefighters, and they go out and they fight these wildfires. And then when they get out of prison, they are not allowed to be firefighters because there's this good moral character requirement. So even if they've done the job for 10 years without pay, they are not able to then go and get paid for the service for a completely unrelated crime. I understand in the case of like arson or all of these other pieces, but why does having a fake ID in college prevent someone in their 40s who's been training as a firefighter for 10 years from being a firefighter? And that's a lot of the things that we have also started to work on policy-wise, is starting to ask those harder questions to people of why is these policies in place?
I just want to underline something that Darwin was telling me about that if our goal is for less crime in society, people need to be able to have jobs. Otherwise, crime is their only option for money, basically.
If you want people to be able to be productive members of society, to be able to take care of themselves, to be able to have this flourishing, they need to be able to go to work. And these barriers are just keeping people from going to work and keeping them back in sort of this criminal recidivism loop that we would like to be able to break by instead having opportunities to allow them to engage with society.
Right, our next question is, along the lines of public information, what would you like to see vis-a-vis about how to train patients when to make the choice to use a primary versus a nurse practitioner when coming in for a complaint they have? This strikes me as a crucial gap in information.
And, you know, this is one of those places where I think it's really a little bit more up to the market. And what I mean by that is, we've realized that this is an issue in healthcare for a long time, is how do you think if you're going to go to a physician or if you're going to go to a nurse practitioner? In many states, they don't tell you, right? You have to go to a physician. The rules say you have to go to a physician. You only have the physicians. But in other places where you do have options to see a physician assistant or a physician associate or a nurse practitioner, you may not realize that actually they only bill at 85% the rate for Medicaid or Medicare services and other things like that. They might actually be a more cost affordable outcome. And they might also be a group of people who specialize specifically in primary care. They deal with the sore throat issues far more often than that physician does. So how do you pick in between the two? So some insurance groups have started listing on their website, hey, this might be a good idea for going to a nurse practitioner. This might be a good idea for going to a physician, much the same way they do urgent care versus emergency room. If it's a bee sting, you go to an urgent care. If it's a swarm of bees, you go to an emergency room. And thinking about those differences, and this is something in just marketing and communication. It's also something that luckily there are public forums for. There's educational pieces about it. Many hospitals have now started being able to say to patients coming in, hey, we know that you're signed up with this physician. Did you know that you actually see a nurse practitioner whenever you come in and the physician's just signing the paperwork in the back? Would you like for this nurse practitioner that you have been seeing to be your primary care physician? So it's going to be communication from the hospital side. It's going to be communication from insurance. But at the end of the day, I don't think the government is necessarily doing a good job at educating individuals. So why is that the barrier that they're allowed to put into place?
Next question is, you mentioned before that the number of hours could prevent people from going into professions like hair braiding. What about the literal cost of licensing? Does that price anyone out of the labor market?
All the time. So a lot of the licensing that we look at, especially a lot of the data was first put together by the Institute for Justice, which is a nonprofit law firm who works on a lot of these particular types of issues for low and medium income employment. That's where a lot of our initial data came from. So at first we started working at this low income employment. The people who are being asked to pay $4,000 for a license for a job that's going to pay $13 an hour. Those are substantial costs and oftentimes do end up pricing people out of the market, which is why we see many different places in like the construction industry where it's particularly hard to get new workers. I don't know if anybody's tried to get their house remodeled lately, but I'm in the middle of buying a house right now, and West Virginia has some of the toughest laws related to being able to get people to work in the construction industry because of the high cost of licensing. And that there's no recognition of licenses from other places. So I can't call a company in Pittsburgh to come help me in West Virginia. I have to be able to get someone local to West Virginia. So these hurdles that have happened have made it so not only is it very difficult for me as a consumer to be able to get help, it is preventing people from being able to work in those professions. There might be someone who's a great carpenter, but it's just not financially feasible for them to pay about $1,000 a year while they're starting up their business at first. There might be someone who would be an awesome cosmetologist, but paying $14,000 and then making $8.50 an hour plus tips at Great Clips afterwards is not a financially viable system for them, which means that now that they're going to be underemployed or maybe unemployed and they can't work in this profession that they're passionate about. So that's many of the hurdles that we're seeing that we would really like to see addressed.
And I just found out that the license to busk, which is literally putting your hat out and playing an instrument in New York City, is $40 a day. So you have to make $40 before you, which is crazy. Native New Yorker.
We've been to Charleston, South Carolina before. Charleston, South Carolina tried to recently put in a license for, there'd be children on the side of the road who made roses out of reeds, and they would like sell them for $1. It's now a very expensive license. Every one of these 13 and 14-year-olds now have to register with the government. They have to pay $300 to $400. Was the license that they were proposing. This hasn't eventually gone through because it's something that we've actually been talking to them. It's a bad idea. So all of a sudden you have low-income families who are using this as a type of just income. They're making $1 on each one of these, being asked to pay $350 every single year. That becomes expensive very quickly.
And this next question, we have about a minute and a half left, but it's a great question to end on. So other organizations like the Institute for Justice or the Pacific Legal Foundation also do great work in occupational licensing and con laws. Do you coordinate or interact with them?
All the time. So I think sometimes people forget that university centers, we want to be outward facing. We do the educational piece, but it's who uses that education and who uses that research. We'll get calls all the time from Pacific Legal Foundation about con law, where they might want to know what it's like in a particular state, or they might need education related to how does this impact financially the local population. The Institute for Justice often gives us calls when they're working with, for example, we did some work with them on lactation consultants in Georgia. They were going to change a policy that basically would make every single lactation consultant in Georgia unable to do their job during the formula crisis. So when there were not other options. So that was one that they called us, and we looked at what the quality impact would be, what the access impact would be, what the financial impact would be to many of these families. And we were able to help them assess these pieces too. So we work with many different types of organizations, everybody from local governments to law firms to different organizations such as the American Association of Nurse Practitioners, the American Medical Association, the American Association of, basically, you name it, they've probably called us at some point to ask a question, and we are here to just provide the education that they're interested in.
That's great. And like I said before, we really appreciate the work you, the Knee Center, and all the other researchers working on this are doing, because it's incredibly important. You're saving lives and making people better off, giving them access to things that they didn't even know were being withheld from them. So thank you so much. And thank you everyone for coming to this. We will have more crucial conversations coming up, so please keep an eye out for the invitations for those as well. Thank you.
Thank you, everyone.